Good afternoon. Welcome to the limb salvage and wound care session. Let's start with the first talk. This is what I want from my revascularization colleagues, and this is Dr. Carman from Cleveland.
Hi there, good afternoon, and thank you. It's a pleasure to be back. I don't have any disclosures relative to this. So we have a few guidelines from the ACC PAD guidelines that tell us what we should expect in our patients who are either undergoing revascularization for chronic limb ischemia or critical limb threatening ischemia, and that is that we should expect an evaluation by a multidisciplinary care team. So it's important to realize how many people are part of that team. Similarly, the recommendations for wound healing therapies also recommend that interdisciplinary care team provide comprehensive care to the patients to achieve complete wound healing. So who is part of the care team? Well, from this same manuscript, this is the care team that the ACC identifies. So the reality is, not infrequently, when you're in the clinic, you are somewhat alone. So take this example, a 58-year-old lady has long-standing history of diabetes. She has other comorbidities. Hemoglobin A1C is poorly controlled, and she dropped a can of beans on her foot 6 weeks ago, and now she comes in with toe pain, right? So, my picture didn't show up. Nonetheless, it was a very nasty toe, all right, with surrounding cellulitis, exposed bone, and distal gangrene. So then when you're faced with that patient, you're asking yourself, how many different people am I going to have to involve just to manage this single case? Well, obviously, from a medical standpoint, we need to get the endocrinologist involved or the primary care doc, whoever is managing that. We definitely need to make sure we acutely manage the toe with the need for vascular lab imaging or peripheral studies. We need to make sure we get an MRI or some form of imaging to help our surgical colleagues. She's likely, depending on how sick the foot is or how sick she is, may need to be admitted. We may need infectious disease involved. We probably are going to need our peripheral vascular support involved, and then we're going to ultimately have to have podiatry involved. So one person, one 30-minute consult, and the downstream distribution can be quite complex. So realistically, day to day, this is my home team, and these are the people I deal with every single day. Nursing support, the vascular lab, home health care, and DME providers for virtually every patient, orthotists, prosthetists, diet and nutrition counseling, and then physical therapy and lymphedema therapy. Those are not uncommon. That's for a routine wound. And this is what my office frequently looks like, right? It is not easy to keep all of those parts moving on any given day. The realistic part is it takes a very complex team to heal complex wounds. We need a host of professionals with clinical experience to help us. We need a host of different reperfusion specialists, whether it's our interventionalists or our surgical colleagues, and then we need our ancillary medical support. And then our surgical support. Colorectal surgery, not uncommonly for some of our complex wounds, but podiatry routinely, plastic surgery, orthopedic surgery, etc. So this is realistically what our care team looks like. And I'm sure if you do wound care, you can name the individual who's your go-to in each of those boxes. But that's a really complex situation that you get yourself into. So what do I want from my revascularization colleagues? I need good communication because I'm going to have to communicate on any given day with all of those different people. I need to know what the referral process is. If I have somebody with an acute limb, how do I get them to you today? If I have somebody with chronic limb-threatening ischemia and I need them to be seen in a week, how do I get them there? Or if I have routine needs, how do I get them there? Is there a specific contact person? Is it a general contact process? Do you want to see the patient beforehand? Sometimes that would be helpful. Who's going to be primary when the patient comes into the hospital? Am I the admitting service? Are you the admitting service? Do we have to worry about somebody else? Past that point, if the patient comes back into the hospital, notify me if there's an unplanned admission, or notify me if there's a delay in care or a delay to the anticipated procedure, because that becomes very important. I have to communicate with the patient also. Afterwards, keep me in the loop. Was the procedure successful? What do I now have available? I can go back and look at the angios, and frequently I will, but let me know as you're leaving the table. It's always helpful. Tell me what you want as far as anticoagulant therapy or antiplatelet agents. I can help with that. Not infrequently, the patients may not remember what you told them when they went home, and I can help with that. Tell me about the surveillance requirements. Again, I'm happy to help. Patients miss appointments all the time. If you don't catch up with the patient, I may be able to gap catch them. And any other laboratory needs, et cetera. Is there a reason I should delay my secondary procedures? Sometimes there is, all right? And then, most importantly, let me know if something complicated happened. So when the patient comes back and they're not happy, I can also help explain that we're just not always successful. So the reality is I see these patients every 1 to 3 weeks, depending on how sick they are, how sick their foot is. The patients with these wounds are not always the most medically sophisticated patients, and we do struggle with some of that. We reinforce a lot of care needs, a lot of behavior, and I'm really happy to help with all of those medical issues and those communication issues going forward. So every team needs a captain. We tend to play that role in the wound center. Every player on my team is important, all 20 plus of them. Everyone has the same goal, and limb salvage really is where we're all headed. So with that, I will thank you.
Thanks so much, Dr. Carman. I think you're going to follow yourself here with the ABCs of wound care, which is great. Always great to follow, and just I think we'll hold our questions till after your next discussion.
For the record, I saved 2 minutes on that first talk because this one is going to be a tour de force. So this is normally a 40-minute talk, just so you understand. All right, so I have no disclosures. So wound healing is a very complex process. In acute wounds, wounds want to heal. They heal within about 14 days. When we are left with chronic wounds, they don't move through those normal stages of healing, of hemostasis, inflammation, tissue formation, and reepithelialization. Then we get into trouble. We have a disorganized, unhealthy base that we need to help progress in a concerted fashion. All wound management is actually very systematic. It starts with assessment of the patient and the wound, determine your diagnosis, do any additional diagnostic studies or procedural studies that you might need to do, and then apply good clinical practices. And those practices really are very basic practices. And then if things don't heal, you have to step back. You may have to biopsy, you may have to reassess your etiology, or you may have to look at other secondary etiologies. So here are my ABCs. And unfortunately, there's not one of A or B or C. But assessment of the patient and the wound, and then an accurate diagnosis is very important. If you don't know what you're treating, you won't get there. On the B, blood flow, both from the arterial standpoint as well as the venous standpoint, and then managing that wound with balanced tissue moisture. C, some of the most important. It needs to have a clean base. They need to be frequently debrided, good compression, appropriate contact avoidance or offloading, and then comprehensive patient management. Again, these are sick patients with a lot of comorbidities, generally speaking. So the patient history is actually a very thorough, comprehensive history. This history is no different than any other complex vascular patient in my office. The wound history adds to that background. So knowing what the wound has done, how it's progressed, what other things have been tried, and all of the cofactors and concomitant associations of the wound become very important. Get your accurate diagnosis. Almost all wounds fall into 5 categories: arterial, venous, neurotrophic, pressure-related, or trauma-related. But we have a whole host of mixed etiologies and atypical wounds, and when you have a wound that's not normal, you have to step back and say, what are my atypical categories might I run into? If we go now through the B's, blood flow is very important. We always start with a pulse assessment. That doesn't necessarily tell you what you have in the forefoot, but you certainly begin with a good pulse exam. If you can't feel the pulses, use your handheld Doppler. Grade those grade those signals as either being monophasic or multiphasic, and if you're monophasic, you have to proceed with more evaluation. Ankle brachial index, pulse volume recording, segmental pressures, we use them as our first line of non-invasive tests. We certainly reserve CTA, MRA, and angiography when revascularization is anticipated, but I also have no problem ordering that from the wound clinic if I know I'm going to be giving my interventionalist a call in the next week. Don't forget about the veins. Many of our wounds now have a concomitant venous component, and it's not uncommon that we have mixed arterial venous disease. Duplex ultrasound and venous insufficiency scanning can give you a lot of anatomic as well as physiologic information about what's going on in the venous system. It doesn't really diagnose chronic venous hypertension for you. That's a clinical diagnosis, but you still need to know what's going on the venous side of things because it does complicate your care. We have good data that says fixing these veins early helps us heal wounds. This applies to both to straight-up venous wounds, but also in our mixed arterial venous disease. Sometimes this is our go-to. And from the EVER trial, we know that we can shorten our time to healing, shorten our recurrence rate, and prolong our ulcer-free intervals. Balanced tissue moisture. This is one of the most important concepts. If you have a moist base, we need to dry it out. We use our products and our components to help absorb that exudate. If we have a dry base, we add moisture back. We need to keep that balance. If we have a neutral base, we can protect and support and move towards reepithelialization in many, many different ways. We also need to have a clean base, so we debride these wounds frequently. They need to be free of devitalized material, free of any necrotic debris, free of slough, and free of friable hypergranulation tissue. We also don't want them free of microbial contamination, biofilm, and obviously no infection. We don't throw antibiotics at these wounds, but we do a lot of mechanical and topical control of our biofilm. We can do debridement in a number of different ways. In the office, we like to do it with sharp or surgical debridement. We don't use a lot of mechanical debridement in the office. We may use that in the inpatient setting, particularly with particularly dirty wounds. Enzymatic debridement with collagenase is certainly helpful. Even autolytic debridement, and you could document it as such, you still get credit for having debrided that wound and having taken care of that wound. Entomologic debridement, usually the patients take care of that. If they want to bring in their own bugs, we try not to use those. How about compression? Compression is actually a very important component of all wound care, and it has to be done very thoughtfully. You can see on the right-hand side of the slide, we have a number of different tools and a number of different things that we can apply to patients to help with compression. And while you'll read in the literature that 30 to 40 millimeters mercury is really how you should heal wounds, that's ideal, that's the best studied. It is absolutely not applicable for all patients or appropriate for all patients. You've got to make sure your compression matches any degree of arterial insufficiency. You've got to make sure your compression that you're going to use can be applied properly by your patients, your caregivers, or frankly, you can get into a lot more trouble. But we do need to make sure the wounds get good compression. It helps with inflammation, it helps with control of the edema, and it helps with overall wound healing. Don't forget that when the patients have lower extremity swelling, there's a number of different etiologies. Don't just assume it's always venous. Don't just assume it's always related to the wound. You have to evaluate these patients. That was part of the a thorough, systematic evaluation of the patient. We have a lot of systemic etiologies that people overlook or may not be as familiar with that contribute to lower extremity swelling. Compression caveats. Use what the patient and the caregiver can apply. If they can't apply it, it's not going to get used. Rule out your systemic etiologies. We don't just throw diuretics at these patients. I stop diuretics way more often than I ever start them. Ask about sleeping habits. 30% of your patients are sleeping in a chair. I will promise you that. At least that's about my numbers in the wound clinic. Make sure they get the foot of the bed elevated and they provide that passive decongestion to help control their legs. Contact prevention or offloading. This is important not just for neurotrophic or diabetic foot ulcer, but even our patients with venous ulcers, if those ulcers happen to be on the back of their calf or if they happen to be on the side of their leg and that's the side they sleep on, any type of contact slows that wound down. I always tell my patients healing wounds is like growing grass. If you plant grass seed and you walk on it, you will never get it to grow. It's the same with a wound. Patients don't necessarily appreciate it, but it's one of the most important and, frankly, one of the most difficult parts of the wound clinic, in my opinion. Again, complex patients require a complex team. We have people that help with a lot of these different components, but at the end of the day, the wound care specialist is the one who's trying to move all these boxes and align all these people into a forward-moving process. So, summary for ABCs of wound care: comprehensive patient and wound evaluation is essential. Assess and address perfusion, both on the arterial side as well as the venous side. Use moist wound healing, compression, offloading, and debridement as part of your routine care. It's stuff that gets applied every day, every patient. And then use your referral sources and manage the whole patient. 5 don'ts. Please don't randomly swab wounds. I can tell you what you will grow, and it's not helpful. If we really need cultures, we use clean, deep cultures in the base of the wound. So don't swab a wound, send it to me, and expect me to put the patient on antibiotics. Don't randomly apply antibiotics. It's not helpful, and we struggle with antibiotic resistance, and it's only getting worse. Don't rely on diuretics for your lower extremity swelling. They are rarely indicated. A lot of times there are other components. Don't be afraid to try initial management. Like anything, when you're a novice, try your initial management. But the biggest issue is know when you're in over your head and know when you need to refer somebody. And then don't omit or overlook your ABCs. So in conclusion, thorough systematic evaluation, assess, restore your vascular integrity, thoughtful wound care, manage your modifiable risk factors, manage your other comorbidities that may be affecting the disease and the underlying success of your wound healing. And with that, I thank you.
Great talks, Terry. We would never leave the outcomes of outcomes such as or the other risk factors like lipid management or hypertension management after a coronary intervention. But here we are basically dumping the care on an outcome that our interventionalists are working on someone else. So there's got to be a lot of trust involved there, right? So let's just say there is an interventionalist who's not a wound care specialist. Let's say Matt sees a patient, Rutherford 5 with large wound, or maybe Rutherford 6 big wound. What are the simple things Matt could do to kind of temporize, or what are the simple things that any interventionalist who manages CLI should have in the office other than Band-Aids?
So that's a really good question. One of my first caveats is if you have necrotic ischemic tissue, until you know your perfusion status, don't touch it. Just don't touch it. You can paint it with betadine, you can protect it, and you've not lost any ground. If you touch it, you create a bigger wound, you open a source of infection, you've potentially lost ground. So that's one of the things when I teach the residents is if you have a monophasic wound or necrotic tissue, just don't go there yet.
So just betadine?
Betadine, dry and quiet.
That's it, okay. All right, excellent. Any questions, you guys?
No, I think it underscores the importance of a teamwork approach, and also understanding that the importance of these patients understanding the complexity. You actually have way more access in the wound care center than we all do. We'll see them for the intervention. We may see them in follow-up. But I think the key thing here is I see my patients 1 every 3 weeks, right? No, but we just can't do that. And I can't get patients in my office. I think working with your wound care specialist to overcome many of those social determinants of health is important, and thank you for doing that.
So Dr. Botek, from your end, you're seeing a patient after critical limb ischemia. What are the determinants that make you call your interventionalist colleague to say, I need help? You have done something to this leg, now I need more help. What are those times, and what do you do with that?
The majority of these times, I'm really consulting prior to any debridement. So we'll work it up, in the office just with palpating pulses, Doppler examination, and then when we determine there's most likely an element of peripheral arterial disease before any debridement, I would then consult a specialist. So afterwards, usually it's more than 1 or 2 days after a debridement, say the patient wasn't addressed preoperatively or was overlooked for some reason, I would just give it a few days. But I think timing is everything, as what was mentioned, so the sooner we can get the whole team involved, circulation is critical. We know that.
So I think the important part here is to identify, to have that collaboration up front, and also for re-interventions as necessary. As Drew said, the interventionalists don't have that many clinic times. These patients are in the wound center, so that back and forth communication that the wound, maybe the primary closure is dehiscing, or maybe new ischemia is seen, or the wound is just not going the way you want. That's at least, those are the times I call my partners and say, I need help. And obviously start with the duplex or the TLR first, and then get them, and my threshold for getting the interventionalists involved is quite low at that point.
I think, Raghu, from my standpoint, it's also important to understand that, a lot of times we'll see these patients, you may get an ABI back or a PVR back that suggests, they're a 0.6, you think you're okay, you're going to be able to, proceed with some conservative wound care until the patient gets infected, right? And then that stage of the wound goes up one, from a Wi-Fi 2 to 3, and the next thing you know, now you need to be able to make that phone call. And that's where it really becomes important, is understanding when things have changed.
All right, good discussion. We will move on. Dr. Klein is going to talk about time to address disparities in CLTI care.
Thanks, everyone. I appreciate it, and what a great talk. And thank you, actually, to the moderators for actually having this talk even included on a program. This is not something I've seen in a lot of PAD conferences, and I want to applaud everyone for attending this, because I do think it's time to act now. So the time is always right to do what is right, and hopefully by the end of this discussion, we will, or I will kind of go over some of the major determinants or barriers to basically to wound care, and as well as care in general. So I have no disclosures either. I'm very passionate about change, and I think we do need to keep moving forward, and we really need to act. And these are some inspirational quotes to that end. So why are we here? The reality is that all our calls to action to date have really fallen short, right? We have not only fallen short of getting more care for PAD and for CLTI, but it's actually driving, the result of it is further inequities in care. And that's worse for patients in lower socioeconomic classes, minority races, female sex, and underserved geographical locations. So let's talk a little bit about that. I think all of us have seen these maps about amputation rates by region. I believe earlier on the last session, someone talked about, well, it really depends upon which hospital you go to. Do you go to a hospital that does a lot of open, a lot of hospital that goes right to amputation, or someone who does endovascular? That really should not be the case, right? You and I may know what hospital and what reputation they have, but the patient doesn't know. And so I think it's really important to understand that these amputation rates need to be minimized to the best of our ability by addressing this at a systematic level. And really what we know about health disparities is listed there. It can often take many, many generations to actually level this playing field. And we really need to start moving towards leveling this playing field as it comes down, as today. Not yesterday, not 5 years from now, but today. So disparities exist. I mean, we all know that PAD affects about 8 to 10 million Americans, but Medicare claims, when you look at 2003 to 2012, there's an increase in PAD in black women and men in the United States, 16.9% and 13.2%, and that's compared to Caucasians. There's a 30% cumulative lifetime risk of PAD for black Americans, 30%, and that does not account for many cases of which we don't even pick up. Black race is an independent risk factor. I don't believe it's a genetic risk factor. I believe it's due to social determinants of health for PAD, independent or traditional cardiovascular risk factors. But for a second here, let's just step back and look at sex differences. Actually, it's very interesting that there's no overall incidence difference by sex for large U.S. populations. However, women are more likely to be asymptomatic or present with atypical symptoms. Very similar to coronary disease, right? They come in and people think, I don't know, I just feel kind of weak, or I've given up, I have a loss of power. That's their claudication. And if you look at Mary McDermott's data, it really actually impairs their functional status. And when they are symptomatic, women have greater walking impairment and they have a greater functional decline. And again, that's out of Mary McDermott's data. What about treatment? Women are actually less likely to receive statin therapy than men. They're less often to be placed on goal-directed medical therapy than men. And they're less likely to undergo revascularization. And when they do undergo revascularization, it's at an older age with more severe disease. So they're not coming in being referred for claudication, they're coming in with a wound. And more often, they require repeat revascularization. Interestingly enough, amputation rates actually have been shown to be similar as of right now between the two sexes. But clearly, there are differences between men and women and the therapy they're receiving, and we need to address that therapy today. How about unawareness, or just not knowing what is going on? Where is the U.S. population at? Everyone in here is very aware of what PAD does. But when they call 2,500 Americans who were greater than 50 years of age, 26% were familiar with PAD compared to more than 65% being familiar with heart disease. So PAD is not really on people's radar screen. In fact, 14% only knew that PAD could lead to amputations. 14%. That's pathetic. We can do better than that. And this unawareness is actually worse in African Americans than in whites. Probably, again, social determinants of health. What about evidence-based medicine therapies in blacks? It's actually lower. It's least prescribed. Especially in women, get the lowest rates. Black women have the lowest rates of statin. Vascular care access and revascularization practices have been shown, again, to have major risk factors. Not only just PAD, black race, along with diabetes and renal disease, is an independent predictor of lower extremity amputation. If you don't know who Fluso Faccaretti is, he's a colleague of mine and all of ours that does endovascular work. The man has independently reduced the amputation rate in a small town in Mississippi by 50% by himself. I asked Fluso, what is the issue with this? And he said, you know how many endocrinologists are in the state of Mississippi? There are 8 in the entire state. So you talk about access to care and ability and social determinants of care, this plays a factor. What about in the VA population? Having formerly worked for the VA, black race significantly increased the risk of amputation within the same socioeconomic stratum compared to white race, independent risk factors that's even after controlling for comorbidities and severity of PAD and use of medication. So clearly there's a problem. Interesting enough, when you look at black and Hispanic patients, more likely to present with advanced disease, 4 times more likely to receive an amputation, less likely to be revascularized than non-Hispanic whites. And black patients are more likely to have early surgical graft failure. Both blacks and Hispanics have higher reintervention rates and lower amputation-free survivals after PVI. Why and what is going on here? Why are we so bad at this? Well, one of the major issues that out there is something called social determinants of health. For those of you who have EPIC, you probably have seen it in the bottom left corner of the title screen of your patients. And thankfully it's still there, but most people don't even know what SDH means. These are economic and social conditions that influence individual and group differences in health status. They play a major role in influencing why our patients don't have medical literacy. They include socioeconomic status, which obviously predict hospitalizations for PAD. Interestingly enough, when you look at social determinants of health, for instance, they can actually be a problem with practice site versus socioeconomic status. For instance, this is from hospital to hospital. So if that patient goes into one practice, they may get a different care than if they go into another practice. And here's the data. Low volume, lower extremity revascularization hospitals are less likely to perform revascularization. This is what we just brought up. They're more likely to proceed directly to amputation versus actually doing an endovascular intervention. And in summary, lower socioeconomic status predicts where patients get care. If this is the only hospital in town, and that's what happened in Mississippi at Fluso's shop, it was the only hospital in town, and patients would often check in, and they would check out with an amputation. And that disparate care available in low socioeconomic neighborhoods meaningfully affects health outcomes. So what are the roots of unnecessary amputation? Well, in summary, it's a failure to raise awareness. We have what I just reported, 14% of people knew that that PAD could lead to amputations. It's a failure of early screening. It's a lack of a multidisciplinary team, as Dr. Carman just mentioned. And it's the delivery of invariable and inconsistent care. We need to understand more specifically what to capture the inequities of CLTI at the community level and hold accountable institutions, policies, precedents, and I would say prejudice as well, so that we can actually address these issues. Where are we today? We know that significant racial and ethnic and geographical disparities exist. This may be due to limited healthcare insurance, we can address that, inadequate access, or other social determinants of health, and implicit bias discrimination. If you're not familiar with implicit bias discrimination, please talk to me afterwards. If you haven't read about it, please do. It's impressive to do a seminar on that. So I was very fortunate to join Cindy Grimes and some colleagues from SCI to talk about racial and ethnic disparities in coronary, vascular, structural, and congenital heart disease. I won't read this to you, but we basically went through and made not only this observation of where things were and summarized the data, but said what you can do at the national, what you can do at the societal, what you can do at the regional and local levels, but more importantly, what you can do at the provider levels. This is about time that we start caring and start doing the right thing. Coming your way, if you've not seen this, is the American Heart Association has joined up with several societies to talk about the PAD national plan. This is perhaps the most comprehensive involvement that I've seen to date in this arena, and it's very exciting that we're finally stepping on board and figuring out how we can limit amputations and improve our health outcomes. And with that, I'll say thank you very much.
Outstanding talk, Dr. Klein, so important. All right, let's start actually with the diagnostic part of CLI. When to use ultrasound, CTA, MRA before going to the Cath lab. Tina Pena.
Almost doesn't seem as important as the talk we just heard, but we'll go ahead and talk a little bit about when do we use ultrasound, CT, and MR in these patients. These are my disclosures. So obviously, when we look at CLI patients, I think it's important that that it's really a clinical assessment when we're looking at the ulcerations and gangrene, and what we're trying to do is assess limb perfusion. And anatomic assessment, like MR and CT, are really surrogates to look at perfusion. We can see different types of charts and kind of algorithms, and really I think it goes to what Dr. Carman said. When you're planning revascularization is when you should be considering morphologic examinations such as CTA or an MRA. What's the goal of imaging? Really, you want to assess the severity of disease. You want to know the level of disease so you can figure out if you can treat it or not. And you would like a baseline examination that you can use for follow-up. I always start with an arterial non-invasive examination, which I think has three major components. One is going to be a PVR with segmental pressures, which will include toe PPGs, looking at a Doppler evaluation, and obviously an ABI. And Matt and Mehdi really, I think, brought this point home when they looked at the relationship between ankle brachial index and toe brachial index in these patients with critical limb ischemia. Nearly 1/3 of patients had normal or mildly reduced ABI. So then Mehdi looked at the impact deep data and saw similar types of results, that the ABI was just not consistent, and TBI seems to be a better marker for these patients. An ultrasound Doppler map, I think, is important. I think it goes along with the waveforms and morphology that we talked about. And I think this, a lot of times, can give us most of the information that we need to plan our procedures. When you look at, again, guidelines, it's really the patients that we're going to revascularize that we should consider imaging for. So how, why, how does it help? Really, for me, I think when I'm contemplating intervention, I want to get the best possible vascular map as I can. I think it allows us to plan our access sites, and today we had discussion about alternative access. Already know option 1, option 2, option 3, but also get an idea of the devices we may use. Do we have them in stock? Do we know exactly what we're going to do? Do we have an idea what we're going to tell the patient what they can expect? And I think it gives a better discussion in terms of risk, of what they plan to do, how long the procedure is going to take, when you discuss it with the patient. A lot of times it will allow you to find possible bypass targets, and you can already have a pretty good understanding of whether maybe this patient needs to go to surgery, or have an idea of what your limits are when you're going to consider surgery when you're starting with an endovascular first algorithm. And again, a lot of times, particularly with CT, allows us to see the amount of calcifications that can exist. And we've already heard about the limiting factor of calcifications and things we need to do as they will affect our results. So all in all, I would say I think this reduces our procedure time, our contrast use, our complications by allowing better planning. CTA seems to be the primary way of evaluating these patients. I think it's because it's readily accessible. I think a lot of times it's something that can be easily programmed, and most places can acquire a good CTA. With some fine-tuning, you can get algorithms that will help you better evaluate the infrapopliteal segments by having a second run that may occur in these patients that may not fill these vessels. But to me, CTA seems to be, it's just easier to acquire. It does help us to get reconstructions, but the real limitations with CTA is that it's sometimes difficult to ascertain or to differentiate calcium from contrast. But in this particular patient, when I'm looking at the inflow, I think it's very helpful. In this particular patient with an aortoiliac lesion, gives me an idea, do I want to try this endovascular, or is this something that someone should go to surgery? Does it involve the distal aorta? How calcified is it? Does it go up to the renal arteries? Here about this patient, a 65-year-old patient with severe bilateral leg claudication. Due to the calcified nature of this plaque in the common femoral arteries, this patient gets referred for surgery. Unfortunately, we see a lot of occlusions, a lot of calcifications in the below-knee vessels. And I think this really limits our evaluations with CT. And a lot of times people lose faith in CTA because they say, I keep getting these CTAs, and they're just really not helpful. I can see the inflow vessels. The ultrasounds usually tell me what that is. I don't get additional information. And I think this is where we start looking at some particular ways how we can modify our protocols in these particular patients. Diabetics, patients that we know have distal disease. And I think our ultrasound can help us identify, once we get a good non-invasive, whether the patient should be an MR or CTA candidate. Here's a patient with CT that you can see some infrapopliteal disease, some calcified disease. We're able to say, okay, we're going to go antegrade. We thought we were going to do, and we planned a atherectomy of the TP trunk in this particular patient due to a calcified lesion. You can see how the CTA compared to the pre-procedure imaging and when we finish the procedure. Again, like I was saying, the challenge of CTA is really in CLI, it's these small vessels that are calcified. And this is really where we rely on MR. So a lot of MR techniques have really changed in the last probably decade. Dixon MRA is just a different way of doing MR. It's a different sequence. It used to be where we would have to acquire a sequence without gadolinium, then acquire one with the gadolinium and subtract them. Dixon allows us to do just one run and it already subtracts the background. So it really saves us time and something that's really changed in the last couple of years. Really the hallmark to evaluate these patients with critical limb ischemia has to do with time-resolved MRA. Be able to create these kind of movies with the gadolinium going through it to really allow the flow and allow you to evaluate the tibial vessels. And I think this is critical in these patients. It gives us an idea how many tibial vessels, where the collateralization may occur so we can already plan our treatments. Obviously, when I show you pictures of normal patients, it's much easier to acquire. But you can see these acquisitions are volume. So we can acquire them in the AP, like you see in that middle image. And if someone clicks on either side, you get an idea. You can take these images, the very same images, and then looking them from the side, from a sagittal view, from a coronal view, and you can get different informations. And you can see that one of the DP on the right is out and gives you an idea of the level of that disease. So here's a 73-year-old with right toe ulcer. You get to see what there is some left disease, but you can get to see the extent. Hey, the anterior tibial, that right lower extremity seems to be out, and then how it correlates with the time of angiography. Sorry, it's not running. Other things that I think are important now is that we can also get some high-resolution images, and sometimes we use this in really difficult patients that we know we're looking at some pedal arch reconstructions and what have you. I think it's much better if I can acquire these images before I get the patient on the table and have an idea whether this is something that we need to do on this patient, as opposed to kind of putting all our eggs in that basket and taking that patient to the lab. This is something that we could acquire pretty quickly. Again, patients need to have normal renal function, which is sometimes a limiting factor in our patients with CLI. A non-contrast MR, a lot of work coming into that. Now we have these sequences. We can acquire these in about 10 minutes. Again, they look much better in our healthy patients, but we're coming a long way with patients with peripheral vascular disease. You can see here a 79-year-old, right foot pain, GFR of 12, good evaluation of the tibial vessels and the pedal arch. So how do I choose? In CLI calcified vessels, I favor MR. I think time-resolved imaging is crucial in these patients. You need to know about their contrast, if they can tolerate contrast and the risk of NSF in these patients with renal that are renally challenged. Again, CTA, it's better spatial resolution. You can do all these fun reconstructions, but it's sometimes difficult to differentiate calcium from the contrast, and that's really a limiting factor in the tibial vessels. So I'll stop there. I don't want to go over time. Thank you very much.
We have time for discussion. Tino, do you mind coming up, please? As you're coming up, I have to mention that every time I see Tino's presentations on this, I feel jealous because we don't have this kind of quality in all hospitals, and we can't send all of our patients to you. So in terms of availability, the Dixon method, is it available everywhere?
You know, I think you're going to have a scanner where they have, I think we're lucky in that, at our institute we have, I think the scanners are pretty much all the same, and I think everyone will probably have a good quality scanner. It's just having the right sequences on that scanner and the coils that go along with it. There are a couple coils, but I think if you were going to say, hey, we're going to send our MRAs to this particular scanner at our hospital, and we want those techs to become proficient at this, you can probably create that. I mean, I think it goes back to what our Carman said. It's part of the team, right? And I think imaging can be part of the team. And if you say this is important to us, I think you can create those protocols and know where to go and get them done.
Do you know how many ferroheme studies are you doing on a routine basis versus NSF? Because I found that ferroheme kind of useful in these patients because they all have CKD to some respect.
Right. So he was talking about a different type of agent, ferroheme superoxide agent. Unfortunately, we can't really even get it anymore. So we used to use these for blood pools. We used to use them for even TAVR studies in patients that were limited in their contrast load, and we could be able to see the vessels. The good thing is you could eject it. It would stay in the bloodstream for a more significant amount of time, so we can do all different types of sequences. Unfortunately, it's stuff that we can't even get. It's dealing with FDA and stuff like that.
Tino, next question. You didn't talk about this, but I think you are using laser speckle flow imaging too, aren't you?
We used it at some point. We just didn't, it never really took off for us in terms of that use. We used in the Indocin green. We used got it from the OR, from the plastics. Got people that were using them for their flaps and stuff. It just became very difficult. Ideally, with some of those studies, you can do in the office, right? And the question is, could we get an assessed perfusion in the office by using these studies? But they required, central access and injection and cost, and that, I ran into too many hurdles.
The footprint itself, it's huge.
Yeah, I ran into a lot of hurdles.
Got it. So, anyone using laser speckle at all, the FlowMet device? Okay, all right. So that's just basically little non-invasive probe that you attach to the foot. I feel that the advantage or the future of that potential device is going back to what Drew said, is we don't have time to see patients, every week after these interventions. It'd be nice to have some sort of, small device that is actively monitoring the patient for perfusion, and maybe there'll be an inflection point at some point where that alerts. I got a text now sitting here that someone's INR is 6. So something to that effect where as providers we get that alert that the perfusion is going down. Get them.
Yeah. I bet you we all have those patients that we try to see every week or have someone see every week. We're like, okay, I'll see them this week. You see them 2 weeks from now, because we know they're like teetering, right?
Correct.
And if we had a system like that, right?
That'd be great.
There used to be that implantable, we did that study with that implantable little thing, a sensor, something like that. So if we knew the blood flow, so you probably didn't necessarily need to see them. Yeah. But the only way you know is by seeing them, so it makes it tough.
Yeah. Great, thank you.
All right.
Any questions for Drew? How can we, my quick question, how can we increase the participation or enrollment of more patients that are Black and underserved?
So I think the first thing is to understand is that all of us have implicit biases that may or may not influence. So I think getting your own personal training, I think understanding that this is about advocacy. We're not very good as interventional cardiologists and as a team to be advocates. And this really needs to take a systematic process. And though you may not be ready to campaign Capitol Hill and talk to your representatives, I think understanding where your limitations are. So being in Atlanta with a large African-American population, understanding where the cultural barriers of care are. What is it that really prevents this patient from understanding? They probably didn't have the education. Maybe they grew up in an area with food deserts and they don't have good access to care and their diabetes is poorly controlled. And it's a systematic problem. So you're not going to fix that overnight, but you can change something for you. And I think the key thing is in what we provide in the document in CCI was really what you can do at a provider level, what you can do at a healthcare level, and then regional, and work your way up. But I think it starts really with us and kind of figuring out where your things may be and understanding what's access to care. Can you get your patients in? There's so many challenges we all need to address to really start leveling the playing field, but the time is now to really start leveling.
Drew, I just wanted to commend you for the excellent presentation, and I think it's incumbent on all of us to get involved. I mean, the reason these disparities exist and the reason it's so hard to change is we live in an environment of fee-for-service, and there's no reimbursement or incentives to do this stuff. So we're going to really have to redesign care delivery in order to make this stuff happen, and that's going to take a lot of stakeholders. But just like all politics are local, all healthcare is local. And it is not to say that you can't influence change in your community by getting involved with this. And as Dr. Fukaretti has shown, with fairly limited resources, he's made a tremendous impact. But to Dr. Carman's excellent presentation, it takes a village to take care of these patients. And that village really needs to own these patients. And I think that's where we're going to start to move the needle.
Yeah, it's just one patient at a time. You just got to start with one patient at a time and never give up, because that one patient may go back and influence their family. And Dr. Carman's work may say, you know, wow, look at, you know, my uncle, he had this wound healed because it was this problem, and they really dedicated. Now I'm going to get my other uncles and my other aunts and my cousins and everyone else to start going into the clinic, and it can make a big difference. So never too late to start today. Okay, we're gonna move on to what a functional amputation is. Georgeanne, one of our podiatrists, I think it's most important. I've learned so much from the podiatrist over the years. It's a never-ending growth for me every time I interface with our podiatrist, so I look forward to learning what a functional amputation is in a little more detail from Dr. Gray.
Thank you. So I'd like to talk about a few cases where patients were offered below-knee amputations and we discussed other options in terms of preserving function. It's a passion of mine to treat patients to a functional level. In an ideal world, it would be nice to omit all amputations, but we know that's not necessarily feasible, even though we strive for it. There comes a point, though, where amputation is the best selection to preserve quality of life and make a patient more functional, resolving infection and ischemia. Unfortunately, in 2022, I feel like the state of amputation is arbitrary. Whether or not a patient is offered a below-the-knee amputation or a partial foot amputation can be dependent on the surgeon, the service who's on call, the mood of the surgeon perhaps, and just arbitrary in terms of the outcomes and what signifies when a patient has a major or minor amputation. If we take this case, for example, this is a 61-year-old African-American male with diabetes and end-stage renal disease, our typical patient population. Peripheral neuropathy. He presented with this right foot to the emergency department. He probably delayed his treatment because he was still shell-shocked from the below-the-knee amputation he had on the contralateral side within the last 6 months. So we can see the vast tissue destruction to the distal lateral foot, a pinpoint ulceration to the medial midfoot, and a heel ulcer, which fortunately did not probe to bone. It was more fibrous in nature. His x-rays on first glance, osteomyelitis to the PIPJs of the third and fourth toes, but looking a little bit closer, we can see actually an osteolytic lesion to the medial first metatarsal as well. As is typical with an admitted patient, we'll now get an MRI. An MRI on T1 and T2 images also confirmed osteomyelitis to the third through fourth rays distally, as well as the first metatarsal, which was somewhat surprising. PVRs and TCPO2 tests were done as well, ABI of 1.38, so falsely elevated, but as has been said today, I look at the TBI, the toe brachial index pressure of 0.40, to me indicated relatively good circulation to the midfoot and forefoot. He did have mildly dampened waveforms. Probably mudding the picture was his TCPO2s were below the normal range of 40. 3 out of the 4 sites were abnormal, but on a borderline level, like 35, 37, 33 with 145 reading. But we have to take into consideration these leads and look at the quality of the skin. You can see that lichenified callous xerotic skin, which probably also contributed to the results of the TCPO2s. So the surgical plan for many services was to offer this patient a below-the-knee amputation. Vascular surgery, plastic surgery weighed in, as well as infectious disease, whose obvious goal is to eradicate infection and would agree with the surgical proposal. Podiatry also related that based on the quality of the skin, the infection, circulation, that this patient probably did not have a salvageable foot. However, the patient refused an amputation, so he was in the hospital with IV antibiotic therapy and wound care, and then a change of services occurs. But I'm sure we all in the room can relate. We have patients in front of us that state they'd rather die than lose their limb. This is not an uncommon sentiment. And these foot and ankle surgeons out of Texas kind of looked at all of surveyed their patients of about 540 and found that patients feared losing their limb greater than death. And I could probably relate to that in my own patient population. So I offered the patient a transmetatarsal amputation. It was a single-stage procedure with primary closure. We worked with infectious disease, and he really went on to uneventful healing. About 4 to 5 weeks, we can see he had a lateral wound dehiscence, but that was superficial, and we did employ hyperbaric oxygen therapy, wound care. My patients all see the wound care nurse postoperatively, thankfully, weekly for the most part. And I just saw him a few weeks ago, and he's doing well. He's walking very happy and leading a full life. Many papers talk about transmetatarsal amputations, and the reason for failure is really across the board: end-stage renal disease, PAD, ischemia, infection. But this particular paper also looked at function, and from a patient's perspective, how they looked at a minor amputation, meaning below the ankle, versus an above the ankle amputation after TMA. They had 146 patients at a limb salvage center in Washington, D.C. Infection rate was about 17.8% across the board. The majority were a success. 105 of the 146 TMAs were a success. Those that went on to higher level amputation include Chopart amputation, which is at the level of the talus and calcaneus, the Liz Frank amputation at the tarsal metatarsal joint, and 18 had a below the knee amputation. If we look at the results, really pretty similar in terms of ambulation and mortality, but slightly increased, right, and improved in the TMA, or the partial foot amputation, where 85.7% were ambulatory and 6% mortality rate within a 2-year time period, which was a little bit surprising to me. That's a short time period to have nearly a 30% mortality. But I feel like every limb matters, every person matters. So even when we see these comparable results, 75% versus 85%, 27% versus a 34% mortality, we see a difference between the higher level amputation. If we look at reasons for failure of the transmetatarsal amputation here, peripheral vascular disease and infection. A little bit surprising that the postoperative infection outweighed ischemia, but I think that tells us, just it's a good remembering that we are improving our circulation and our peripheral arterial disease and our co-management and multidisciplinary care on that front, but we need to work on that infectious component. Also interestingly, even though infection rate was a 4-fold increase in rate of failure, it wasn't dependent on post-wash cultures. So as a surgeon, after we get that foot out and we're irrigating and cleaning it out, we get post-wash cultures. Even though that might have been positive in this case, that wasn't indicative of the failure or the infection post-operatively. If we look at another amputation level, such as a Chopart, we look at this patient who came into the emergency room, obviously with a prior history, a partial first ray amputation, a wound to the posterior heel that had been managed by plastics, and vascular surgery offered a below-the-knee amputation, which is probably maybe expected, as well as plastic surgery, who had been managing this patient prior. If we look at his circulation, it's not ideal. We have diminished waveforms, PVRs at the mid-tarsal and forefoot, but we're not looking at really salvaging the foot here. We're looking at a more proximal amputation of the foot versus a below-the-knee amputation. The patient is absolutely adamant that he does not want a below-the-knee amputation. He's a preacher, he's running for office in a few months for a county auditor, and doesn't think he could win that election if he had a below-the-knee amputation at this time. So my colleague and I reviewed his MRI, which demonstrated osteomyelitis through the midfoot and forefoot, and we decided that we weren't making any promises, that's for sure. We always tell our patients that they're at high risk of a major lower extremity amputation. But we staged it. We did a medial ray resection, took out osteomyelitic bone, Used a Masonics debrider on his foot, and then we can see his first stage procedure where part of the midfoot was taken for cultures. He was off antibiotics for about a 10-day period of time, and then had negative pressure wound therapy with installation. Surprisingly, 2 or 3 days later, we thought, this looks pretty darn good. He has a good soft tissue envelope. It looks relatively clean. We have good cultures, infectious disease on board. He is responding to Levaquin or Bactrim, actually. So a second stage procedure was performed with primary closure. We did vac the ankle, the chronic wound, and put an amniotic stem cell product on that area. About 4 months he was healed, primarily 3 to 4 months, but his ankle wound persisted for a little while. But by 5 months he was in a brace and walking and had a good outcome. The choke part amputation is more biomechanically off, right? We're losing a lot of the soft tissue, but with soft tissue rebalancing and attention to this, not having an overpowering posterior muscle group, eradicating infection, and really working with these patients closely in the postoperative period, we can have a success. So once again, failure is often attributable to infection. If we compare lower limb amputation, major versus minor, minor being below the ankle versus major, there's a place and a time for both of these procedures. I would say that we really need to consider a more major amputation, perhaps in that younger patient, less than 50, who needs to get on with their life, cannot be dealing with infection, disability, ischemia, and it has pain. If we look at minor amputations, we want to improve quality of life. We have to make sure we eradicate infection to get a better outcome, and it's incumbent on us, the podiatrists and foot and ankle surgeons, to do a better job at muscle soft tissue rebalancing, eradicating infection, and having a good perioperative and postoperative course. Thank you.
Thank you very much, and we'll follow up with some questions after I get to introduce my co-moderator, Dr. Kolluri. He's going to give us his talk on mixed venous and arterial ulcers. This is my approach. Raghu?
Thank you. Don't really have any conflicts specific to this topic, but those are my disclosures. So let's, to define the problem, the incidence of arterial disease in patients who present with venous ulcerations is about 15 to 30%, and of which moderate PAD is seen in 13% of the patients and severe in only 2% of the patients. But it's still something that we see if we see enough wounds or if we deal with enough CLI. So the most common questions, the whole talk will basically try to address these two questions because these are what we are asked: to compress or not to. And then if I am compressing the leg, is it graduated compression or something else? What type of compression should we be using? And then the next one is, should we compress first or revascularize for the PAD? So let's look at the available data. I'm going to warn you that these are all very small studies, mostly published from the Gloucestershire group, and the first one was in 1998, where they took patients with moderate arterial disease and venous ulcerations and severe arterial disease and venous ulcerations. Severe arterial disease in 1998 study underwent arteriography and then arterial bypass, and one got angioplasty, and after that, venous surgery. If it's moderate arterial disease, they use modified stiff compression, which we will talk about, inelastic compression. Those that failed modified compression underwent angiography and angioplasty or bypass. If they're non-reconstructible, then they underwent venous surgery. At that time, this was basically stripping of the saphenous vein involved. So in the three groups, the first one basically is essentially pure venous ulcers with ABI of 0.85, maybe mild PAD in some of those patients. 2 is those with moderate PAD, and 3 is those with 0.5 or less severe PAD. And as you can see, the group 1 and 2, the ones with either mild PAD or no PAD had up to 60% healing at 36 weeks. And then when you look at the severe ones, you had only 20% healing at 36 weeks. The same group, a decade later, more contemporary for its time, again, looked at patients who had ABI of greater than 0.85, less than 0.5, and 0.5 and 8.5. And again, similarly, they either treated with revascularization for severe disease or modified for moderate disease, and if they're mild, they compress them. So in this, again at 36 weeks, those who did not have arterial disease, 86.8% of the ulcers healed. Moderate PAD, 67, and severe was significantly different at 53%. And the biggest thing in this study that caught my attention is the 30-day mortality of 6.5%, saying that these patients with combined disease are probably very fragile overall. So it's important to remember that. Again, move on a decade further, 2013, this is a different group, 20 patients, 17 with moderate PAD, 3 with severe, and they were treated with compression first for moderate, and those with severe underwent revascularization, and those who underwent revascularization had much shorter healing time. So based on these 3 studies, albeit small, the take-home message for the first question is arterial revascularization helps with wound healing in patients with mixed arterial venous, although the studies available are small studies. What about compression? So here is another small patient study, 25 patients with mixed arteriovenous ulcers, ABIs in the moderate or severe range. Toe pressures were more than 30, though. They applied inelastic bandages from 20 to 30, 30 to 40, or 40 to 50 millimeter mercury, and then they measured laser Doppler fluximetry at the ulcer, at the toes, and they looked at TCPO2s of the dorsum also. What did they find? Well, the laser Doppler flux values around the wound essentially improved with 30 to 40 millimeter mercury and even 40 to 50 millimeter mercury. It was not statistically significant for 20 to 30. But when you look distal to the bandages in the toes, the Doppler flux was lower with 40 to 50%, but 20 to 30 and 30 to 40 actually improved the perfusion in the toes. Similarly, TCPO2s were elevated with 31 to 40, and then the Cath ejection fraction was also improved with 20 to 30 and 30 to 40 millimeter mercury. So even though these patients had moderate PAD, the inelastic compression, not the graduated compression, seemed to help. And these helps, the inelastic compression will help improving skin perfusion, toe pressures, and calf ejection fraction. So we have to be very careful. I tell my patients and their family members if they have any discomfort that they should take those away immediately, because then that's compromising it. In most of my patients with these mixed arterial venous ulcers, I also use arterial flow device, which creates sort of a negative pressure to at the arteriovenular end and nitric oxide. And then there was recent meta-analysis also and a systemic review of these intermittent pneumatic compression devices that helps with claudication distance, wound healing, amputation reductions, and good for patients with no options, or could be used as an adjunct as well. It's very difficult to get these things approved, though. Most have peer-to-peer. Last week, one of my patients actually bought it. He had Berger's disease and a venous ulcer. So this looks busy, but let me walk you through it. I have time, according to the timer. If a mixed etiology patient comes in, obviously the first thing we'll get is ABIs and toe pressures. Granted, ABIs may not be entirely accurate, but presuming that we looked at the PVRs, toe pressures, we categorize them into normal ABIs, moderate, or severe. If they're normal, obviously, you'll put them in 2 to 4 layered compression wraps, wound cares, and also endovenous therapies. But if I see patients with infrapopliteal disease, I try to spare that saphenous vein because in my practice, I've seen so many patients whose all saphenous veins have been ablated in vein centers, and there's no good conduit. So I try to actually save that unless it's massively dilated. If it is moderate PAD, again, as we just talked about, gently applied 2 to 4 layered stiff compression socks, educate the patients and family. Again, endovenous therapies, very careful. Unless they are large, we don't. If they don't heal, then go to what the severe PAD patient population is, that red arrow, and angiography, revascularization. If the patient is unable to be revascularized, again, go back to gentle compression, arterial flow device, close monitoring, and prevent infection. It becomes sort of a palliative care at that time. Once revascularized, again, based on what their post-intervention status is, they go back to the normal or the moderate PAD flow. So again, these are complex patients, but revascularization helps and stiff compression wraps help. Thank you.
Thanks, Raghu. I appreciate it. We're next going to end up here with last two talks. We got This is What I Want from my podiatry colleagues. Matt Bunte's going to come up and tell us what his perspective is from podiatry, or what you want to learn from podiatry.
Great, thanks. This is going to be a very similar talk to, I think, the one Dr. Carman gave earlier. These are my disclosures. Very similar schematic, but just representation of the different elements of diabetic foot ulcer and CLTI management. And in yellow, on the left, these are the areas I particularly lean on my surgical colleagues in my practice to help with wound and debridement and reconstructive surgeries, offloading and orthotics, and minor amputation, major amputation, and some folks is needed certainly, but many of these patients don't require that. So I created basically a kind of illustrative case here in a top 10 list, so we'll go through the case. So this is a 71-year-old gentleman with a diabetic foot ulcer and osteomyelitis, and like many of these ulcers, it's been ongoing for a significant amount of time. He had a history of a left TMA about 18 months prior, and then subsequently developed this left heel wound and was subsequently diagnosed with calcaneal osteomyelitis on MRI. He had a partial calcanectomy and a wound vac was placed. He went through 2 rounds of parenteral antibiotics about 3 months before I met him here, and now he's admitted with persistent left hindfoot not healing. But the other challenges, the rest of the story is that his A1C is 12%, and he's got AKI on top of CKD4, so he's nearly on dialysis. He's got pretty advanced systolic heart failure. He's homeless. He's certainly not offloading, and he has no primary care physician. So where do you go from here? And, this top 10 list is a list of attributes that I expect of myself as well, and probably the number one is just to have availability and support, prompt assessment, coordination of PTOT services, offloading recommendations, surgical support if it's needed right away, that we make a plan together. And so this gentleman, because of his non-calcified ABIs and the lack of a toe, we performed transcutaneous oximetry, and at baseline, all of his partial pressure of oxygen at that ankle level was pretty poor. So we took him for angiography. He had a focal pop angioplasty. He had an unsuccessful revascularization of the TP trunk and posterior tibial artery previously, but we were able to restore single vessel runoff on this admission. And so the problem, of course, though, is his ulcer is in the hindfoot, on the bottom of his foot, far away from this nice dorsalis pedis. So the other thing is just communication. And, these patients are complex, as we've multiple points in our discussion this afternoon. We've noted that how important it is to address the follow-up issues and coordinate these complex patients. And so, the patient ended up having an IND, but we kept him on a fairly short leash. And, while his wound was improving with the IND and wound care, it still wasn't resolving. It kind of plateaued. So providing that feedback as part of communication was really integral in this case. So this was a patient that we performed a deep vein arterialization on for limb salvage, and the patient was, like many of Dr. Botek's patients, she mentioned this guy did not want to have a below-the-knee amputation. He had enough psychosocial issues going on, and so immediately after the deep vein arterialization, you can already see that hibernating network of microvascular supply to the hindfoot. And so he went on to, with diligent wound care and offloading and a lot of social support, ended up healing completely over about 10 weeks. And, the other thing I look for is quality. And, I expect high-quality medical care on my end, but I also want to make sure that we're quality-oriented, particularly with offloading the other recommendations that the U.S. Wound Registry and Podiatry Registry recommend. Some of these cases require really creative procedural skill and surgical solutions, and so that's something that I really value in the podiatrists that I work with. And some of these patients, with some of these flaps and fixators, it gets very complicated to help prepare these patients and their families for what's to come is an important part of this too. Options for Charcot arthropathy are really valued. These are very complicated patients just medically, but then you throw on all of these biomechanical challenges. It is wonderful to have a resource to deal with these difficult orthopedic issues into the foot. A passion for limb salvage is, a willingness to take on tough cases. And when below-the-knee amputation has been recommended by other folks to, it may be appropriate, it may not be. There may be a window or an opportunity to salvage, and until you try, you just don't know. I say that all the time to myself with some of these endovascular cases. Familiarity with the options and process of limb salvage, and then understanding the predictors of amputation and urgency of wound closure. The predictors of major amputation that certainly make me more concerned, though, are the wound duration and if osteomyelitis is involved. But many of these issues can be addressed with good surgical care. I love a willingness to educate, and it works both ways. And I think if we understand each other's pinch points and problems and challenges, I think we are a more effective team. I think prioritizing post-op care and surveillance and really being a committed partner in the post-care of these patients after they've undergone revascularization and their INDs and they're out of the hospital is really important. Also to encourage the healthy lifestyle changes in preventative foot care, creating relationships with patients long-term, and resources in case of future issues. And then lastly, just teamwork. These patients are very, very complicated with some of the psychosocial issues that they have, and so if we can help each other out with follow-up on the same day and kind of bending over backwards to accommodate the patient and their needs is really awesome. So to kind of summarize, this is the top 10 list of what I want from my podiatry colleagues, and I'll stop there. Thanks.
Thank you, Matt. Next is must-read articles in CLTI. Peter Monteleone. I'm looking forward to this talk.
I'm excited about this talk. It's going to be fun. Hello, everyone. Thank you guys so much for having me. These are my disclosures. And we're going to talk about must-read articles in CLTI. And that is a broad topic, because it's not just must-read in 2022. It's of every article ever in CLTI. Let's talk about must-reads. So set some criteria. One, we don't want to make all new, some old, some new. I noticed this was the 450 CVI Day 3 talk, so we'll try and be a little inspiring and interesting and fun. We're going to focus on the content we sometimes ignore as busy clinicians. And so rather than it being must-reads, it's going to be must-reads as we talk about these cases, because things that we wouldn't necessarily come across in our busy clinical practices. So to begin, thinking about what our patients would face without the work done by this society, practitioners in this field, by this group. So in the 1990s, 1997 and specifically, there was an article that was put out that was talking about patients with critical limb ischemia. The nomenclature was a little different. They called it critical if you had a wound and subcritical if you had rest pain. And it said, well, as we try to optimize care of these patients and do what we do in 1997, what happens to them? And they die and they lose their limbs. So the 1, 3, and 5-year mortality in 1997 was 26, 44, and 56% respectively. Even more impressively, at 1 year in 1997, that lower risk cohort, 73% of them didn't make it through the year alive and with their leg. That patient who actually had tissue loss, 95% of that patient population lost their limb at the end of 1 year. So it was really striking to think, we sit at meetings like these and we ask ourselves, let's look at a bunch of trials that show a 10% improvement using some new device versus some other. But the steady onward march of this field has been remarkable in terms of what we accomplished. So number one, and must read, a little bit of historical memory of where we came from. Number two, so the goal for a second article is to think about the fact that every CLTI patient is different. Every wound is different. Every patient is different. One of the places this is best summarized is a historic trial about wounds, or that we've heard talked about in other talks here, the Wi-Fi classification. So thinking not just about blood flow, thinking about tissue, thinking about the wound itself, thinking about the infection in the wound. And so there's been a couple actually wonderful presentations on this topic for folks who are either new to the field or invested in the field or increasing their exposure in the field. This is a great article to really dive into, to think about the fact that every wound is different, and it's a good reminder that every patient in front of us is different as well. The original article worked to tease out which components of ischemia and wound and infection were actually predicting a worsened outcome. It's since been externally validated, and that Wi-Fi score has also been translated into other elements of patient care and patient quality of life throughout our field. So another real important article. Next one, something to remind us that we joke about being plumbers sometimes, but we really need to be good doctors and clinicians. And this is a 2022 article. So the diabetes control and complications trial started in 1984, and they started looking at conservative therapies versus intensive glucose control in patients. And just in 2022, there was an article that was published which demonstrated a 23% absolute risk reduction through aggressive, intensive medical therapy to control diabetes for prevention of a first wound. Now, if there was a laser or an atherectomy device or a stent that you can put into your highest risk patients at midlife and prevent them from ever having a first wound, that would be our most commonly used device. It'd be on every escalator and hotel room key at CVI. And so the concept that careful monitoring and managing of high-risk patients in advance can dramatically impact their future of even entering into a CLTI cohort is something that these articles really can remind us of. And staying broadly read in this field of prevention for our patients, even beyond arterial intervention, is a huge component of our reading in CLTI. Next, to remember that we've not done a great job ensuring that all of these scientific achievements are distributed equally among our patients. And so Dr. Klein and the panel has done an excellent job kind of diving into this closely and carefully. There's another very nice article, including the one that Dr. Klein had pointed out about consensus discussion, not just in PAD, but also in structural and coronary intervention. The Society of Interventional Radiology put out this consensus panel discussion, which talks on a number of topics in this field of disparity. And there's descriptions, and I know the text is a little small, but it'll talk about disparity in our recognition of these patients. It'll talk about disparity of the presence of disease in these patient populations. And it'll talk about how bad we've been at studying the care of these patients to advance the care of these patients, which is an essential foundational ask. Now, we are making some advances in this, and I'm going off algorithm a little bit because the Elegance trial is not yet published. But this is, we're proud in Austin to be part of the Elegance trial, sponsored by Boston Scientific. It's looking at how the Alluvia drug-eluting stent and the Ranger drug-coated balloon can be utilized in patients with PAD with a specific focus on underrepresented patient populations, women and underrepresented minorities. What's listed here is an email that I got. So we started Elegance as a site in mid-June. We pride ourselves in being real fast, efficient recruiters. And so 2 weeks later, we'd put 6 patients into this trial. We got an email telling us that the goal was to be at 2/3 at least, or actually 4/5 at least, women and underrepresented minorities, and we were at 66% effectively white males. And so we got an email from Boston Scientific telling us that if we didn't correct that ratio, they would shut us down as a site. And that's a brave thing to do, because clinical trials are usually focused on being efficient and cost effective, and telling a fast recruiting site that they're not focusing on the populations they want to focus on is a huge deal and a big step forward in this field. Next, remember that technique has taken us so far. So this is another kind of pat on the back for us as a society. So there was a paper published on technical success and complication rates for retrograde arterial access just in 2022. And it was a PRISM analysis. They pulled 33 trials, and they looked at technical success, and technical success, which was defined as the ability to cross a lesion from below, and procedural success, the ability to have an effective treatment of a lesion when working retrograde. Now, we've been doing retrograde work for years, not decades. You know, in 2014, one of the panelists, the good Dr. Bunte, and myself, under the guidance of Dr. Shishabor, managed to get a paper published about 20 patients that were treated retrograde, and that was 8 years ago. And so now, all of a sudden, we're at a place where there's 30 different clinical trials using retrograde access of high quality that demonstrated a 96% technical success using a fairly inexpensive therapy that many of us use, and use it casually and use it frequently and use it efficiently now. In terms of the actual procedural success, it was as high as 91%, so demonstrating that a relatively new technical procedure can be extremely, extremely effective. Number next, and almost at the end, staying humble in the face of bench science. So there's Dr. Janet Zoldan at the University of Texas. She runs one of our stem cell biology labs. Dr. Zoldan, who I work very closely with, she proved that you can take mice, immunosuppressed mice, you could ligate their femoral arteries, and then if you inject the right nanotubules and the right angiogenesis factors and the right stem cell progenitors, you could prevent that mouse's leg from dying by doing that in the right way. And every once in a while, when I'm sitting in a cath lab and I'm banging a wire against a lesion for 30 minutes, I'm thinking about Dr. Zoldan injecting stem cells and preventing a mice leg from dying with no artery. This is a wonderful review of a lot of these therapies in angiogenesis as well as stem cell therapy. It's like a 15-page document, but I really recommend it for folks, both interventionalists and vascular medicine doctors in the field. We all hope that a revolution is coming in our ability to use kind of angiogenesis models, stem cell models, to improve both the plumbing, but also to improve the true tissue perfusion at some point in our patients and right now in scientific models. And then the last one, to remember that nothing is more important to our patients than our training of the next generation. A wonderful consensus document focused on CLTI care came out from SCI, from ACR, APMA, SBS, SVM, all of a number of the large societies, not just within one field, talking about how we train the future practitioners that are going to care for this. And like a lot of these consensus documents, it talks about medical knowledge, and it talks about practical application, and it talks about all the things our trainees should be focused on. And it's great for those of us that work with trainees to finally have a set of responsible guidelines by which to train the future. It's also great for folks invested in the field to think about what practitioners coming into our arenas doing this work should be thinking about. These are our new incoming fellows, and we've tricked 2 of them into doing interventional cardiology and at least 1 of them into doing peripheral vascular intervention. And it's really just inspiring to think that all the pieces of work that we're doing now, that we read and that we do and that we talk about in these societies will carry forward for generations through them. So that's the must-read articles in critical limb ischemia.
Thank you, Peter. I think we have some time. Any questions from the audience? Welcome any questions or feedback. Yeah, Christian.
Thank you. I'd like to ask all, including Tino, about perfusion and endpoints. I know we talk all about flow assessment and clinical wound outcomes, recurrence prevention, but we're doing a bunch of stuff. When enough is enough?
That's a tough one. I'll hear what Tino has to say. I actually think there's a little bit of wound blush is perhaps our beacon. I wrote an article a couple years ago about that, wound blush being the beacon for CLI, but I would love to know when it's enough is on the table. Tino?
I think that's the key, right? If we could figure that out, people are doing some work now with pedal, plantar acceleration time in the room. We talked about the FlowMed device, looking at that. Blush, I think, is a great thing when you see it. Sometimes you don't see it. But I think it makes it makes a big difference, because a lot of times we would probably stop if we knew we were there, and other times we would keep going. So curious what the rest of the panel thinks.
And I think it's, I certainly use wound blush in my practice, but I think the other thing I use is my podiatry or wound care colleagues to tell me how it's looking in 2 weeks, and if it's not looking good or is kind of not as advanced, then we start thinking about maybe doing a staged procedure.
I think I agree with that. The reperfusion related issues within the foot in a CLI patient are really complicated. And laser speckle or whatever it is, when we tried our small study like 12 years ago, it was all over the place. On the other hand, it was a perfect linear regression if we correlated that to TBIs in the outpatient setting. So in my opinion, the perfusion assessment of when to stop in the cath lab is difficult. I hope you all agree. And I agree with you that it's more of a clinical endpoint, to stop, see how things are going with our wound care colleagues, and then go from there.
Got a question for you, Raghu. So you had mentioned, you presented some data there about, do you do arterial, do you do venous first, and then it was all ABI based, which obviously we all know is completely thrown off.
So what do you do? Do you go by a TBI? Do you go,
Yeah.
what do you use?
So that's a great question. So I don't just look at the ABI. For every ABI study, we also get pulse volume recordings. So if the ABIs and toe pressures don't match, then we actually categorize severity of disease with pulse volume recordings. So it's more of, and obviously most of my patients will get an arterial duplex mapping also. So it's not just ABI. That's the reason I said we do multiple things in terms of assessing what the perfusion is with the available technology. But it's not just ABI. Thanks for having me clarify that again. Did I answer your question?
It was perfect.
Yep.
And go ahead.
Can I just make one comment along? So one of the things I think it's important to remember when you're dealing with mixed arterial venous ulcers is where is the disease? Where's the level of disease? Because tibial disease is unlikely to help me heal that ulcer when it's a venous stasis ulcer. Does that make sense? It may to some extent impact my ability to do the best compression, but I don't think it's going to help me heal, a Cath ulcer. So I think those are the other things that I look at when I look at a PVR. It's where is my level of disease, and depending on the location, not level being what my ABI is, but depending on the location of disease, then I also can judge how far I'm going to push with something.
Have any of you guys, we talked about, I know Chris White talks a little bit about algorithmic care and the necessity. I think Peter mentioned one of the papers showing that clearly guideline concordant medical therapy not only saves limbs, as Chung showed in JVS in 2007, but Aaron Armstrong went back to say it decreases morbidity and mortality. So for those of you who are having EPIC, I can imagine a single note that includes Wi-Fi classification, medications, checkoffs. Are they on aspirin? Are they on antiplatelets? Are they on? Because one thing that struck me about the data for, I think it was the data showing 30% mortality in these patients. They're all dying from heart disease. They're all dying from cardiovascular disease. And so making certain that they're on good medical therapy, which is the foundation of everything, is imperative. It's hard sometimes because you get so obsessed into one thing to step back and say, are they on a statin?
You're right. We now have only one registry, as we all know, the PVI. And that does require input of these. And I did read a paper, I think 3 years ago, with the statin use in 60% of patients and antiplatelet therapy in 76% of patients. So even though people are inputting it, that itself is not bringing the use up, which is very fascinating. So I don't know. I guess it is who are inputting is probably important too, because then it becomes. I know it is a lot of work, but I hope that the registries will modify behavior. But I was a little disappointed to see a registry from PVI publish those rates.
Yeah, I think there's a lot of opportunities here for growth, not only at the local level and the healthcare level, but you can imagine us moving forward with the registry level and also saying, making sure that we all check each other's back. And just like we hear from the wound care center that, hey, this wound's not healing, you may want to talk about re-angiogram. Same thing, hey, by the way, I didn't see them on a statin. Can you make certain they're on that? Because I think it's important. And then additionally, working through a multidisciplinary approach, really, because that's all CLI. It demands a multidisciplinary approach. I don't think one specialty owns this. It's everybody. So, any other questions? Thank you very much from the panel and everyone for attending. Have a great rest of the conference.